rescheduling the class. We have quite ill babies lah in NICU. Very ill actually. Yesterday also I spent until 2 a.m. with one baby, and then today the whole day has been extremely busy. But that's fine. Okay, all right. So you've done neonatal resuscitation today. Tomorrow and day after, you'll have few sessions in small groups about newborn examination. So the topic that I'm going to speak tonight is actually about newborn examination. Again, lectures with me, you won't expect long lectures. Usually I expect around 1 hour lah, the maximum. I think that should be okay. I think lectures of more than 1 hour is not ideal, especially online lectures. Okay, all right. So I'm going to talk about newborn examination, assessment and care of newborn. So this is actually a slide initially prepared by Dr. Mossad, and then I basically edit and modified from what Dr. Mossad have written before. I can try to go to the next slide. Okay, all right. So basically, newborn examination is the most thorough perinatal exam, and it must be done by undergraduates, graduate, or postgraduates. And we do it in several phases. The first phase is the first hour of life, when we resuscitate baby, when we assess the baby at the first hour of life, and then we reassess again around 1 to 3 hours of life, and then and so on and so forth. So these are among the phases that we usually examine and assess the newborn babies. If we look at examination, usually when we examine a patient, we have something that we want to look for. Like there's an objective. I always tell students, if you clock any patient, if you get history, there are 4 objectives that you want to assess, that you want to reach. The first one is to get to the provisional diagnosis, to know the provisional diagnosis. Why? Because you will be managing the patient based on the provisional diagnosis. Next is to rule out differential diagnosis. And third is to look for complication of the disease. And fourth is to look for complications of the treatment. So when you clock any patient, there's these 4 objectives that you need to fulfill. When you examine any patient as well, there's 4 objectives that you need to fulfill. From your examination, you need to ascertain what is the provisional diagnosis. You need to look for you need to rule out differential diagnosis. You need to look for complications of the disease, and you need to look for complications of the treatment. That is general for all cases in pediatrics. In medicine, you need to look for all these 4 objectives of any history, clocking, any physical examination, and any case presentation. But for newborn examination, it's a bit difficult because you don't have a specific objective. There's no specific complaint other than I'm just being born, isn't it? A newborn baby, do they have any complaint? No, there's no presenting complaint. The only complaint is I'm just being born, isn't it? So 90% of newborn examination are on normal babies. So you don't need to, there's no specific complaint. So it's just an assessment of normality. I always tell medical students, if you do physical examination, the first thing that we assess you in short cases and so on and so forth, for your case, probably the modified long case, when we assess you, the first thing we look at is how is your approach? Do you introduce yourself properly? Do you communicate well with the patient? How is your approach? Second, we look at whether whether you are a safe doctor, meaning do you clean your hands before you touch patient? Do you ask when you move any limb, when you move the patient, do you ask whether there's any pain? Do you look at the patient's face when you assess anything that may cause pain to the patient? And are you a safe doctor? This is what we assess. Is your hands always visible? You don't remove the patient's clothing by yourself. So are you safe or not? So this is what we assess. Third is we assess whether your technique is good. So first, approach. Second, safe doctor. Third is technique. Whether the way you percuss is correct or not. The way you measure things is correct or not. How you feel, how you auscultate, how you do things. Technique. The fourth is we look at whether you know what is normal. Whether you know this is a normal finding. And fifth, only we look at whether you are able to identify a positive finding. That's only the fifth objective. You see, again, when we assess you for physical examination, the first thing is we look at whether how is your approach. Second, we look at whether you are safe doctor, whether you are safe. Third is your technique. Fourth is whether you are able to ascertain whether you are able to identify this is normal. Because if you do not if you don't know what is normal, if you say this is abnormal, then you are creating finding. Creating something that is not there is more dangerous than not finding something abnormal. Faham tak? If there is an abnormal finding, but you cannot find it, you don't know it, then we can guide you. Do you want to examine again? We can guide you until you find that abnormal thing. But if it's abnormal, if it's normal, then you say it is abnormal. You are creating finding. Creating finding is a sin. Creating finding is a sin. You do not deserve to pass if you create findings. If something is not there, then you say it is there. Then you do not deserve to pass. You are not safe. Okay. So the thing is with newborn examination is majority of them are normal babies. It is an assessment of normality, assessing and confirming that this baby is actually normal. Okay, all right. Next is priorities in delivery room and the first hour of life. The first hour of life is the most important hour for any human being. So we look at whether the baby is able to progress towards the proper adaptation for extrauterine life. You know, we know when the baby is being born, the cord is clamped, isn't it? And then the baby starts to cry. What happens when the cord is clamped? You are removing the low resistance circulation by the placenta. Again, I've mentioned before, blood pressure is cardiac output times total peripheral resistance. Kan BP is cardiac output times total peripheral resistance. Cardiac output is stroke volume times heart rate. Okay, so there's systemic circulation, there's pulmonary circulation. Pulmonary blood pressure, systemic blood pressure. Systemic blood pressure is affected by the low resistance circulation given by the placenta. The moment you remove the placenta, you remove this low resistance circulation, there's a net increase in the total resistance. There's a net increase in the total resistance. There's a relative increment in terms of the resistance. And when the baby starts to cry, the chest starts to move. Fluid is excreted because of the chest compression when the baby goes out through the vagina. And there's compression, so push the fluid, amniotic fluid out, and then the baby starts to cry, expands it creates some negative pressure, expands the alveolar and the airway. What happens is fluid will be absorbed through the lymphatics. What happens is the airway, the bronchioles, the alveolar starts to be filled with air, and air has lower pressure as compared to fluid. So there's no more compression. Previously, the lung is filled with fluid. There's compression and causing increase in the pulmonary blood pressure. Increased pulmonary resistance results in increased pulmonary blood pressure. But the moment the airway, the lung, the alveolar is filled with air, there is reduction in the pulmonary resistance, reduction in pulmonary blood pressure. So what happens is adaptation into extrauterine life, there is a relative reduction, there is a relative increment in terms of systemic resistance and relative increment in terms of systemic blood pressure. But there is a net reduction in the pulmonary resistance and net reduction in the pulmonary blood pressure. So whether this transition happens or not, because if this transition doesn't happen, what will happen to the baby? If the pulmonary blood pressure is higher than the systemic blood pressure, what's going to happen? There'll be right to left shunt. Right side, before going into the lung, the blood is a deoxygenated blood, high in CO2, low in oxygen, isn't it? So there'll be right to left shunt because you expect the PFO is not closed yet, PDA is not closed yet, kan? If there is high pulmonary blood pressure, lower systemic blood pressure, so there'll be right to left shunt. The baby will be cyanotic and so on and so forth. If you assess the ductal, this morning we discussed about ductal SpO2, isn't it? Ductal saturation, preductal. So preductal is right upper limb. You assess preductal and you compare with postductal. Preductal, before the shunt happens, so the SpO2 will be higher. Postductal, because there's right to left shunt, so SpO2 postductal will be lower. So this is what you can see. There's pre and postductal SpO2 discrepancy by more than 10%. So that is a sign that the baby has pulmonary hypertension, persistent pulmonary hypertension of the newborn. Okay, so you assess what? You assess the whether the baby is able to adapt into the extrauterine life. You assess the Amgasco. We'll go through what is Amgasco after this. You assess whether there's any obvious dysmorphic features. You assess whether there's any major congenital anomalies, whether there's any sacral dysgenesis and so on and so forth. You assess cardiopulmonary assessment, whether the heart rate is okay, and whether we need any support. We assess thermoregulation. We need to make sure that the baby has is normothermic. The thermoregulation is normal. We make sure the blood sugar is okay, and then we look for urinary and urine and also meconium, passage of urine and meconium. But some babies, they pass meconium and urine around 24 hours of life. What is Amgasco? So Amgasco is the assessment of basically we assess at 0 minute, at 1 minute, we assess at 1 minute, we assess at 5 minutes, and we assess at 10, 15 macam tu. 1 minute, 5 minutes, 10 minutes macam tu. So what is the scoring? Dia ada color, heart rate or pulse, reflex, grimace, muscle tone and respiration. 0, 1, 1 and 2. So like this lah, kalau color dia blue, score dia 0. So normal good Amgasco score is 10. I think we discussed about in my lecture on birth asphyxia, I mentioned how do we diagnose HIE. So Amgasco score of less than 5 at 5 minutes and 10 minutes of life. So this is Amgasco score. What are the other signs of respiratory distress? The cyanosis. Cyanosis may suggest that the patient is in distress. Grunting. What is grunting? Grunting ni apa? Grunting ni breathing macam dia push dia. Basically what happens is grunting ni, the baby tries to close dia macam you tengah tegan tu. You nak buang air kan, you tegan. What happens is you close the vocal cord, you press, you increase the intrathoracic pressure. So the idea is when the baby increases the intrathoracic pressure, it will help to open up the airway. So that's the idea. So that's grunting. So grunting is a sign of respiratory distress. And flaring of the nostrils, chest retraction, chest in drawings, and so on and so forth. Heart rate of respiratory rate of more than 60. Newborn babies, the respiratory rate can be normal up to 60. Or there's bradycardia or tachycardia. Wait, sorry. Okay. All right. So next is about thermoregulation. Sorry. So how can we, how can we lose heat? We lose heat by several methods. First is conduction. So conduction is by contact. So there's conduction of heat from the body into other surfaces and so on and so forth. Some surface conducts heat better than other surfaces. Next is by radiation. By meaning by environmental temperature and so on and so forth. So radiation is affected by the environmental temperature. That's why we call it radiant warmer. Radiant warmer tu heater kita bagi dekat atas, but there's create a warmer environment. So giving heat by radiation. Next is by convection. Convection ni macam kipas lah. Dia kipas, dia pusing kan. So more air movement, more heat transfer by convection. Next is by evaporation. So evaporation is, you know, energy is, you never lose energy. Energy is being transferred, is being changed. So what happens is when there's fluid, for evaporation, fluid changes into vapor. Fluid changes into vapor. So, and the byproduct is you are going to lose heat. Lose heat by evaporation. So that is why, this is the reason why in premature babies less than 32 weeks, we don't actually dry the baby. We just put, because if you dry the baby, there still be some fluid in it, and then this fluid will be evaporated. So in extreme premature babies, we just put the baby inside a plastic wrap, so that to prevent more heat loss. To prevent more heat loss. Normal vital signs in newborn babies 36.5 to 37.5 degrees Celsius, heart rate 110 to 160, respiratory rate 30 to 60, less than 30 is bradypnea, more than 60 is tachypnea. And then blood pressure, we usually look at the mean gestational, the mean mean blood pressure. We look at the gestational age, meaning a term baby, we expect the mean blood pressure, systolic blood pressure, diastolic blood pressure, and mean blood pressure. We expect the mean blood pressure to be 40. A baby that is 36 weeks gestation, we expect the mean blood pressure to be 36. A baby that is born at 30 weeks gestation, we expect the mean blood pressure to be 30. So usually the mean blood pressure equals to the gestational age. And oxygen saturation, we expect 95%, but again, SpO2, we expect to change according to the minutes of life. So voids, urination, and meconium, we need to document from birth if the baby has passed meconium in utero, during resuscitation, or after resuscitation. So sometimes we do miss urination because at the time the baby is full with fluids, amniotic fluids, and so on and so forth. But we do need to document. We expect meconium and urination should be present within the first 24 hours. If it's not, then something is wrong probably. Probably the baby is dehydrated and so on and so forth. The problem with newborn babies is they do not know how to complain. If adults, if bigger children, if you are dehydrated, they'll tell you, I'm hungry, I'm thirsty, I have headache, I'm in pain. But newborn babies, they can't really tell. Bigger babies, they can tell if they are hungry. Sometimes these newborn babies, if they're hungry, what they do is they sleep, because they don't know how to complain. So this is the problem with them. That is why in newborn babies, even if they have meningitis, even if they have pneumonia, even if they have whatever disease, usually the most common presentation with them is actually just poor feeding. That's the commonest finding that we see. Meningitis ke, pneumonia ke, whatever, the commonest finding is, the commonest presentation is poor feeding. Okay, all right. So for gestational age, this morning we discussed. I asked you, isn't it? Why in before when you being called, we ask 4 questions, and then when the baby is born, we still ask 3 questions, and one of the question is gestation age, because sometimes when the baby is born, the gestation age is different from the expected gestation age. How can you assess gestation age? Is by the Balat score. Balat score should be done within the first 24 hours. Ideally, it should be done in the delivery room. And sometimes we do reassess again in the ward because sometimes findings may differ. This is Balat score. This is not a good photo, but this is what we do lah. So basically, we assess the posture of the baby. The more premature the baby, the more straight the posture is. Kalau dia flex macam tu, biasanya is more term baby, because the muscle tone is poorer in a more premature baby. We assess the square window of the hands, of the wrist, kan? Kalau more term baby, dia punya square window dia lebih rapat. Kalau more premature baby, square window dia tak banyak macam tu. So this is the square window. We assess the arm recoil, we assess popliteal angle, scuff sign, heel to ear, and so on so forth. Skin. Kalau bigger babies, older babies, we can see parchment dia deep, kedut-kedut tu dia deep, kan? Dia ada cracking. Kalau more premature baby, skin dia akan shiny macam tu, kan? Lanugo is the hair dekat belakang dia, kan? More premature baby lagi banyak hair kat belakang dia. Bukan hair kat depan. Hair kat depan tu chest hair tu, geng-geng ambil bacan banyak lah, kan? Tapi maknanya in babies, biasanya hair dekat belakang dia, that is lanugo lah. More premature the baby, more lanugo. We look at plantar surfaces. Premature babies, dia punya plantar dia tak ada crease, flat, smooth saja, kan? The bigger the baby, the older the baby, we can see more plantar crease. The breast pun sama. Kalau premature baby, dia flat je, kan? Then dia start ada areola. Start ada areola dia berapa besar, ada bud dia, ada breast bud dah, and so on so forth. Berapa sentimeter. So we look at the bud, we look at the ear. Ear ni dia recoil. Term baby kita lipat, dia akan terus ready recoil, immediate recoil. Tapi kalau premature baby, you lipat, dia tak recoil balik. And then genitalia, male and female. So contohnya kalau male, more premature baby, scrotum dia tak ada dia punya apa nama tu, ruge. Dia tak ada ruge, flat, smooth je dia punya scrotum dia, kan? In female, usually normally the labia majora should be bigger, kan? Labia minora dia kecil saja, tak nampak pun. The more term, the more you don't see the labia minora. But in premature babies, the minora is big, and so on so forth. So you dapat score dia, bagi number dia, you tengok score dia, dan dia akan bagi dia gestational age. This is very interesting actually, because you can see, I discussed with the Jawatan Kuasa Fatwa Pahang, they ask, kan, because there's a fatwa in Pahang saying that this is different Pahang and Perlis. So Perlis says even if like if you're married, the baby can still be straight away be bin to the father if they are married. But in Pahang it says 6 months. If you're married 6 months, then only you can consider the baby to be their child, because they say less than 6 months the baby is not viable. So if it's more than 6 months, then is the baby of the father. So you can put bin to the it is considered. But the thing is, when the baby is born, we can assess. We know already this baby is 6 months or less than 6 months or more than 6 months. So this is interesting lah for me. So again, we look at skin. Vernix ni yang putih-putih kat kulit dia tu, kan? Vernix, more premature baby, more vernix. And especially babies yang contohnya infant of diabetic mothers, memang banyak vernix. And breast tissue, ears, I've told you before, creases on the sole, and then the posture. Crack skin. So more term baby, you can nampak crack skin. Kalau premature baby, you tak nampak crack sangat lah. This lanugo, rambut-rambut kat belakang dia. Ear, preterm infant, if you lipat dia punya ear dia tak recoil balik. Dia stay macam tu je. Breast pun sama. Areola dia small saja, tak ada nampak breast bud sangat, and banyak lanugo. Plantar crease, this is more term baby. Plantar crease dia sampai ujung. Kalau more premature baby, it will be flat and smooth. As I told you, the labia majora is very small. You can see the labia minora. Clitoris pun nampak besar. So you can compare. See, preterm and term. With the term baby, the labia majora is big. In preterm baby, the minora is big. This is term baby. You can see scrotum. Scrotum, there's lots of rugae, and the testis is well descended. This is the posture. If you see here, term baby at the right side, posture dia flex kan. Kalau premature baby, dia more extended. More the muscle tone is less. This is resting posture. And then we assess the nervous system other than the tone. We assess whether there's head lag. More premature the baby, more head lag. Morose reflex. Again, morose reflex is among the primitive reflexes. We usually will lose primitive reflexes by around 8 months, because by 8 months you will have the, biasanya budak-budak dia pandai duduk by around 8 months kan. 8 months you akan ada parachute reflex, forward parachute, lateral parachute, backward parachute. So you can only stabilize yourself if you have parachute reflex. You cannot sit, you cannot stand if you still have morose reflex. So usually people should lose the morose reflex by 8 months old. And always remember, development will follow corrected gestational age. Development follows corrected gestational age. Vaccination follows chronological age. Do not follow corrected gestational age. Weaning with feeding also follows chronological age, not corrected gestational age. Okay, faham tak? Maknanya kalau baby tu umur dia 2 bulan, dia still vaksin, umur dia 4 bulan, you still vaccinate 4 months. Walaupun dia premature berapa lama pun. Faham? Kalau by 6 months you want to wean the baby into semi-solid, you still wean the baby with semi-solid by 6 months corrected gestational age. By 6 months of chronological age. Sorry, hospital. I need to answer this. Hello, Assalamualaikum. Yep. Okay, sorry. Alright, so morose reflex, routing ni apa routing? Routing ni, so we'll do some of the primitive reflexes tomorrow and day after. So routing ni, if you stroke the cheek, baby akan cari. So this is routing reflex. Sucking reflex. If you put anything inside the baby's mouth, the baby will suck. And then palmar and plantar grasp. If you put anything on the hand, the baby will grasp. Also the plantar, so you put something at the foot, the baby will grasp. So palmar and plantar grasp. Babinski, and then trunk incubation. If you stroke, and then the baby will incurve according to that. Then stepping reflex. Stepping reflex ni, if you stand the baby, if you hold the baby like that, and then you touch a surface with the dorsum of the foot, the baby will step on top. And then there's dancing reflex ataupun kita panggil walking reflex lah. Kalau you put at the surface, baby akan macam walking or dancing. Head lag, morose reflex, we'll do morose reflex tomorrow lah. It's not easy to show here, but I think tomorrow when the practical session we show you how to do morose reflex. Tonic neck reflex ni, if you turn the baby's head towards one side, dia akan jadi macam fencing. So the upper limb that the face is facing, dia akan extend. The upper limb yang opposite dia akan flex. Dia macam fencing. Upper limb and also lower limb pun sama. Jadi kita panggil asymmetrical tonic neck reflex. And then dancing reflex ni, if you hold the baby like that, you suspend the baby ventrally macam tu, you letak kaki dia kat bawah, dia akan macam dance, ataupun you akan nampak dia macam walking reflex. So and then routing reflex, you stroke the cheek, dia akan cari. You letak dalam mulut, dia akan suck. We'll do tomorrow. Grasp, hand grasp, palmar grasp, plantar grasp. Dia akan grasp macam tu. grass. And then basically again, newborn examination is an examination from head to toe. Head to toe. Maknanya you always begin from the head. You look at whatever head circumference, is it okay? Whether there's any molding, you look for caput. Caput basically is edema. You look for bleeding under the scalp. So bleeding under scalp ni ada dua lah basically. Satu cephal hematoma, the other one is subaponeurotic hemorrhage. So cephal hematoma is bleeding. Okay, if you remember, layers of the scalp is SCALP. S is apa S? S is skin lah. Skin. C is connective tissue. A is aponeurosis. L is loose connective tissue. P is periosteum. Below periosteum is your scalp. Kan? So cephal hematoma is bleeding below the periosteum. So you know periosteum covers the bone. So kalau bleeding dekat periosteum ni biasanya bleeding ni because apa? Because of vacuum. Dan bila vacuum dia tarik, dia ada pressure, dia ada pressure tu ditarik. So there's shearing of cephal hematoma biasanya capillary kan. Shearing of the capillary. So they cause bleeding dekat below the periosteum. So bila bleeding below the periosteum, bila ada bleeding, dia jadi fluid collection, dia akan rasa dia dia akan boggy, dia akan rasa boggy, dia sebab dia fluid fill. And then dia bounded by the, so periosteum binds the bone. So dia tak akan cross the midline. Sebab midline ada two different skull bone kan. Dia tak akan cross the suture lines. This is cephal hematoma. The other one is subaponeurotic hemorrhage ataupun subgaleal hemorrhage. This is the same thing lah. Subaponeurotic hemorrhage is a venous shearing, venous bleeding. Maknanya below the periosteum tu dia ada banyak venous bed. So bila because of vacuum, because of delivery apa semua, dia ada koyak dia punya shearing of the vein. So it's a venous bleeding. So bila venous bleeding is difficult to stop. Sebab apa? Sebab your vein doesn't have very strong smooth muscle. So bleeding boleh banyak. And the subaponeurotic space is a huge space. It is connective. It is connected throughout your whole body. Maknanya bleeding tu bila dia isi subaponeurosis tu, dia boleh bleed to the whole body. Kalau siapa pernah lapar lembu masa korban kan, kan dia ada you buka putih-putih tu, buka you separatekan kulit dengan apa kan, that is the subaponeurotic space. So it is connected to whole your body. So you can lose 100% of blood into the subaponeurotic space. So that is why kalau dia ada SAH, subaponeurotic hemorrhage, you kena check. You look for jaundice ke, make sure the baby doesn't go into shock and so on and so forth. Because basically the subaponeurotic space, you can lose your 100% of blood into the subaponeurotic space. How to differentiate between SAH and cephal hematoma? Cephal hematoma does not cross the midline, does not cross the suture, because cephal hematoma is below the periosteum and periosteum covers the bone. But SAH, it can cross the midline and so on and so forth. So and then look at the fontanelle. The fontanelle usually close between 12 to 18 months. Anterior fontanelle and posterior fontanelle usually close by the end of second month. So if the fontanelle is closed early, then you need to suspect something abnormal. Craniosynostosis, for example. Molding is because of how the baby is presented. Sometimes kalau dia present lama dekat bawah tu, prolonged second stage, there may be molding. It's just because the head is compressed. So cephal hematoma, you see, it doesn't cross the midline. So basically, caput succedaneum is basically just the edema. It's a soft tissue edema. Then you go down, you look at the eyes, whether the placement of the eyes is normal. Is there any cyclopic? Kadang dia ada satu mata saja. I've seen babies with just one eye, cyclopic baby, very poor prognosis. It looks scary as well, kan? And then whether there's any slanting, up slanting, down slanting of eyes. Don't use Mongolian faces anymore. You say down slanting or up slanting. Sama juga kalau dia ada line, ada dulu kita panggil simian crease kan. Now don't use simian crease because it looks like it's a bit demeaning. So you say single palmar crease kan. So whether the slanting of the eyes, whether there's epicanthal fold, check the red reflex. You guna fundoscope too, but you don't need to look into the fundus. Just assess whether there's red reflex, because sometimes you may miss leukocoria, congenital cataract, leukocoria. Uh, Usually leukocoria ni, it can be a sign of congenital infection, torches, toxoplasma, rubella, semua. And then blink reflex. You tap, dia blink, glabella tap. And then whether there's any discharges on the eye, pupillary reaction, whether the child is able to follow midline. And then you check hearing, whether there's response to sound. Sometimes dia dengar sound, dia clap dia akan buat morose. And then look whether there's any low set ears. Low set ear ni maknanya the ear, if you make a imaginary line from the eye into the occiput, it should cross the ear. But if it doesn't cross, then probably there's low set ear. So ideally, we should have universal hearing assessment. So all babies should be assessed for the hearing. But the thing is, in many hospitals, in KKM, even in our hospital, we don't have the capability yet to do universal hearing assessment. So we do hearing assessment for babies that are high risk. For example, babies yang ventilated, babies yang on certain ototoxic drug macam gentamicin, or babies yang ada high jaundice. So we do hearing assessment. And then we assess respiratory and cardiovascular. We look at the shape of the chest, whether there's increased epidiameter, sometimes pneumonia, sometimes congenital pneumonia, sometimes meconium aspiration. So there may be increased epidiameter. And we look at the whether there's any abnormal shape of the chest as well from the very beginning. And then we assess whether there's any murmur or not. Biasanya kalau murmur we hear early, usually it is a PDA murmur lah. PDA murmur. VSD usually appears around 5 days. Sebabnya apa? Kenapa tak ada murmur before 5 days usually? Sebabnya initially, if you remember, I told you before, in utero, there is pulmonary hypertension. The pulmonary blood pressure is higher, kan, daripada systemic blood pressure. The moment the baby is born, because of adaptation into extrauterine life, the pulmonary blood pressure drops, systemic blood pressure starts to go up. So usually in the first 5 days of life, the difference in terms of systemic blood pressure and pulmonary blood pressure is not that much. The other difference, but the difference is not that much lagi. So turbulence flow tak banyak kali, because turbulence flow is created by the pressure gradient. Left high pressure, right low pressure, that's left to right shunt. So this causes sometimes VSD murmur, usually after 5 days baru you dengar. Then you assess the femoral and brachial pulses. Kalau ada radiofemoral delay, for example, what's the diagnosis?
Coarctation of
Coarctation of aorta. Then you assess you assess juga sometimes fall-limb blood pressure. And because if there's coarctation of aorta, you see there's blood pressure difference between upper limb and lower limb. Look for abdominal breathing. You need to remember, newborn babies, they are obligate nasal breathers. They can only breathe with their nose. They cannot breathe with their mouth. Kan? If you block the nose, even though mulut dia terbuka, they don't know how to breathe. You assess, these are retraction, chest retraction, subcostal recession, intercostal recession, nasal flaring. And then you assess brachial and femoral pulses, as I've shown before, compare, and then always make sure that the baby is symmetry. Kan, maknanya tangan kanan dengan kiri should be the same lah. Kan, if there's any asymmetry, then it is abnormal. Assess that the baby has complete 5 finger and 5 toes. Tak kurang dan tak lebih. And the fingers and toes is normal. Shouldn't be claw-like, shouldn't be polydactyly, syndactyly, and so on and so forth. Kan? Ada Hindustan punya pelakon seorang ada polydactyly, kan? Wrist erosion. And look at the clavicles. Sometimes like we have one baby in the ward with clavicular fracture. Kan? Dia ada swelling, reduced movement of upper limb that has the fracture. Look for hip dysplastic hip. by doing the otolani and Barlow test, and then whether there's any clubfoot, congenital talipes equinus virus, and look for curvature, cyst, sacral dimple. Sometimes sacral dimple is a sign of congenital of sacral agenesis or spina bifida. Otolani and Barlow. Otolani, basically you try to open, and Barlow you close and press backward. We'll do otolani and Barlow test tomorrow lah. And then look for skin folds, look for whether there's any signs of apa nama tu spina bifida. And then look at the genital urinary, whether the baby is male or female. If there is anything suggestive of apa nama tu ambiguous genitalia, so ambiguous genitalia is a neonatal emergency. Ambiguous genitalia is a neonatal emergency because the baby may go into salt losing crisis, and there's a lot of medical legal issues as well, so you need to sort that out. So assess whether the baby is male or female. If the baby is male, you assess whether the testis is descended. If the testis is not descended, you need to look for the testis. If the testis is below at the base of the scrotum, or the testis is in the inguinal region, so look for the testis. If the testis is not palpable, you need to get ultrasound. You need to look. You need to ascertain where is the testis. Because abdominal testis, sometimes you need to remove, because abdominal testis has a risk of malignant change. So, and then look for the meatus, opening, urethral meatus, whether there's any hypospadias ke apa. Kan? If there's hypospadias, you need to refer properly. And then female, sometimes in newborn babies, you may see pseudo menstruation. Maknanya baby ada some vaginal bleeding macam menstruation. That is okay. That is because of maternal hormones. Maternal hormones. Okay, alright. And then GI, again, assess the passage of meconium. Sometimes something like cystic fibrosis may present with meconium plaque. Look for patency of the anus. I've seen people missing imperforated anus. We only notice after a few days of life, and that is a problem. You should not miss imperforated anus. So check the anus. So passage of meconium does not mean the anus is normal. The anus is pattern, because sometimes they may be passing there's recto-vaginal fistula, for example. So the abdomen should be soft, non-tender, the shape should be scaphoid, and then the bowel sounds are present, and umbilical cord, you need to make sure the umbilical cord is normal, should be 2 artery and 1 vein. And then the skin, you look for whether there's any acrocyanosis, where the cyanosis of the peripheries, there's any lots of discoloration, abstain pearl, erythema toxicum, which is normal, even though the name is toxicum, but erythema toxicum is normal. It's harlequin color, milia, Mongolian spot, port wine stains, and so on and so forth. Look for all these abnormal findings. Whether there's any jaundice, again, I don't know, is it with your group? And jaundice within the first 24 hours is always pathological. And jaundice in the first 24 hours is always pathological. And then, okay, all right. And this is the nomogram for SB, phototherapy. We've discussed this before in hematological punya seminar. Okay, all right, we're not going to go there. So this is subconjunctival hemorrhage, which is okay, sometimes because of pressure. Bila dalam birth canal tu, the high pressure, then sudden release, macam sudden release. So this causes the rupture from the capillary bed. That's okay. Neonatal breast enlargement as well. This is again because of maternal hormone. So that should be fine. Hemangioma. This is milia. This is milia. CTEV. This one. CTEV. Strawberry hemangioma here. Okay. Then, all right. Yep, that's it. Any question? So tomorrow, inshallah tomorrow we'll practice on tomorrow and Thursday lah, Wednesday and Thursday. We practice on babies. You learn about how to do proper newborn examination, and then we'll show you some of the things that we haven't shown this morning during the neonatal resuscitation session. We'll show you the TPs, resuscitator, some of the phototherapy and other things that we have in our NICU. Okay, any question? Any question? Clear? Faham? Okay?
Doktor,
Yes.
examination tu kena repeat. Dia kena orang yang sama examine or can be different.
Ideally, it should be the same. Ideally, it should be the same person lah. But if it's not possible, then it doesn't really matter. So ideally, if you assess, then actually examination is good if the same person do every day. So you know the changes. You look at the heart rate already, so you know already what the changes. Kan? Sama dengan dengue. It's very important actually for the same person to palpate the pulse, because for example dengue kan, one of the earliest sign is the change in terms of the pulse bound, dia punya pulse volume dia. So again, if different people assess at every time, then you won't detect any changes. So ideally it should be the same person lah. But again, this is not an ideal world. Sometimes you don't have the opportunity for one person, because you cannot work more than 24 hours lah. Well, you can, but you'll be exhausted lah. Okay. Right. Any other question? Tak ada?
Dr. Syed, I have a question.
Yes.
When we need to use pre-ductal or post-ductal oxygen saturation?
So assessment of saturation is part of the NRP. So during newborn resuscitation, so the current NRP that we are using, SpO2 is not compulsory, but babies that need some resuscitation, we do need to assess the SpO2. Kan, ideally SpO2 we always put on the pre-ductal. So we compare pre and post-ductal kalau it is abnormal or we think there is any pulmonary hypertension. So pre and post-ductal assessment, kita letak serentak pre and post-ductal is to look for any discrepancy. If the difference is more than 10%, so this suggests that the baby has pulmonary hypertension. Okay, boleh clear?
Okay, thank you, Dr. Syed.
Any other question?
Doktor, yang NRP tu yang bila kita tunggu for 20 minutes kan, until we pronounce patient tak survive tu, kita kira 20 minutes tu from at what time?
From beginning of
minute tu.
from beginning of resuscitation. There's a lot of factors, because sometimes do you manage to get the baby as soon as after birth? Sometimes we get the baby, sometimes the baby is born as well. Then you see the first time you saw the baby already 5 minutes, for example. But generally we take 20 minutes from the moment you begin the resuscitation. The longer you wait, the worse the outcome. Again, I just want to remind everyone, sometimes you are able to keep the patient alive does not mean you are successful, because sometimes the goal should not be to keep your patient alive. The goal should be to keep to allow the patient to have good life. So that's what I think that should be the goal. That should be the goal. I've had cases before. We've had a baby who was admitted at around day 5, I think, and then admitted for jaundice, but collapsed in the postnatal ward. We don't know the reason, probably infection or something. So the team run and then it's quite far from NICU to postnatal ward. It's quite far. There's a lot of doors with keys that you need to open, and so on. It's quite difficult, especially at night. Baby collapse at around 1-2 a.m. So they run over, and then the moment they arrive, it's already 10 minutes already, and then not much resuscitation was done. So because they don't know, they resuscitated the baby for more than 20 minutes. I think around 45 minutes they resuscitated the baby. Yes, they managed to save the baby. The baby is alive until now, but the baby has very bad cerebral palsy. The baby, it was admitted for months in NICU, and then had cerebral palsy, was admitted almost all the time throughout the year. Setiap kali masuk, stayed in the ward for a few weeks, and then discharged home for 1-2 weeks, and then readmitted again. Like that, the whole year for many years. So it disrupted the whole family, and it's such a huge burden to the family. So sometimes you're saving the child's life does not necessarily mean that you've saved the life of the baby and the family. So I'm not saying you should stop. I'm saying that you need to think, what is the goal? The most important aspect, as we've discussed this morning, the most important aspect is actually identifying the risk factor. So you should know which baby has higher risk factor to have more problem, and we need to help the baby from the very beginning. If we do things early, we can settle more things rather than we begin at the end. Okay, right, fine. Question? Okay lah, all right. I think that should be okay. It's 55 minutes. That's fine. That's good. Okay, let's end our session with Tasbih Kafarah and Surah Al-As. Okay, all right. Okay, Assalamualaikum.
Thank you, Doctor.
Thank you, Doktor.